So if you would like to introduce yourself.
My name is Chris Harding. I'm a urology consultant from Newcastle, and I'm the current chair of the BAUS section that covers female urology.
Thank you.
I'm Roland Morley, previous chair of the section, consultant urologist in Imperial London, and I was involved with the NHS England Mesh Review and also seconded to the Scottish Mesh Review.
All right.
I'm Jonathan Duckett. I'm a consultant urogynecologist from Kent. I'm currently chair of the British Society of Urogynaecology, and I've had similar experience as Roland with the NHS England Mesh Review and the things that have followed on from that.
Thank you.
I'm Swati. I'm a consultant urogynecologist at Sheffield Teaching Hospitals, and I'm current vice chair of the British Society of Urogynaecology.
Thank you.
Andy Williams. I'm a colorectal surgeon at Guy's and St Thomas's, and I'm the present chair of the Pelvic Floor Society.
I'm Shabab. I'm a colorectal surgeon in Essex, and I'm the treasurer of the Pelvic Floor Society.
Right. Well, thank you very much indeed.
Can I ask who the observers are? Not that you're not welcome in any way, but just so we know what your background is, because that might be useful, perhaps.
So we're in communications team, I receive communications at the Royal College of Obstetricians and Gynecologists, and BSUG are a specialist society as well as independent of the Royal College.
Fantastic.
So we'll be here later.
That's very helpful, thank you.
Right. So if I could just start by asking you, and it's really up to you who wants to answer the questions. So I'm not going to particularly mention one of you to answer it, but I'd just like to ask you first of all, in your opinion, how safe is the use of mesh in the procedures that you're going to be talking about today? So I don't know who'd like to field that.
So we've learned quite a lot about the safety of mesh that has been researched recently within the NHS. So we've relied previously in the past on randomised controlled trials, which may be of short term and may not give us all the answers for the longer term. But more recently, we've been using large data sets, so NHS England data sets, which give us, we think, fairly accurate and good levels of risk associated with TVT-type mesh procedures, more so than the prolapse mesh procedures. So we can understand we hope, fairly accurately of the risks associated and also from the randomised controlled trials, the benefits of the various mesh procedures. The NHS data suggests that 3.3% of patients will have a mesh removed by 9 years, having had one inserted for stress incontinence. So other data possibly suggests a complication rate of up to 10%, although those may be minor complications. So we have a figure of somewhere in the region of what the risk of a TVT or a synthetic suburethral mesh procedure is. In terms of success, which we always like to think about as well, and it's important in counselling our patients, both the risks and the dangers. A study of 40,000 tapes from the British Society of Urogynaecology database suggested that 94% of our patients were complication-free and had a good outcome with synthetic mesh operations.
Right. Do anybody else want to?
So I think the data that we draw on is as good as we've got at the moment, but there are obviously inherent flaws in all of them. You know, we're talking about high-level evidence, and as consultants we're trained to give that the highest priority, so things like Cochrane reviews, big meta-analyses, and you know, a lot of those outcomes have been centred around treatment and cure of stress incontinence rather than complications that are being reported. So actually the move across to using large data sets such as HES and NHS digital data has been, I think, a positive one and enabled us to get some real life data within there. I still think the issue is, you know, we can talk about percentages and rates and things like that, but actually the nature of complications we still don't know. So we've got a HES data set of over 90,000, which talks about a 10% complication rate, but if you actually drill down and look at the appendices to that paper, 50% of the complications are classified as complications not classified elsewhere. So that really doesn't give you any specifics with regards to the nature of the complications. So that is the evidence gap at the moment, and I think that remains.
Can I pick up on that? Can you just say to me, tell us, the panel here, what are the complications and were they unexpected? Because one of the things that has come to our mind is the paucity of research when this was first introduced and the way that it really took off, these particular operations. And so really concerned about understanding, as you see it, the complications, what they are, and the percentages, etc.
So I think that the complications that are listed in the current RCTs that are available, things like mesh erosions, failure, chronic pain, and they're all fairly reasonably detailed in the reports that have gone previously, such as the MHRA report, the York report, the European Union review. They've looked at those. But a lot of the RCTs were powered to look at success only, i.e. cure of stress incontinence, so therefore it's very difficult to assign any level of accuracy to the ascertainment of complications. But what a lot of the patients are saying is that, you know, many of these complications are not occurring for a significant way down the line following their surgery, and a lot of the studies are just short to medium term, and the ones that are long term, you know, there's dropout rates and things like that, so they are prone to error. So there is, in my mind, still an evidence gap in terms of us being able to fully counsel patients with regards to the risks of mesh surgery. But then the real life data has advanced us a little bit in that regard. So we've got the HES data, which goes out I think to 8 or 9 years, and then the recent JAMA paper, which goes out to 9 years, and that's looking at reoperations and removals. And I think, you know, that gives you a broad idea, but it still doesn't answer specifically and accurately the question that we need to answer, which is the nature of the complications and the variety of them.
Because there are some reservations about using HES data, which I'm sure you're well aware of. So thinking about the insertion of mesh, how is that? How does that compare with other procedures that could be used instead, in terms of safety, in terms of complications, in terms of removals?
We probably need to make a distinction here as well, because we have mesh inserted for vaginal wall prolapse, which has been graded by NICE as only usable for research purposes. So I think when most of us are talking about mesh, most of us are referring to retropubic synthetic suburethral slings, which is the only operation that the urologists would do. So when we're talking, most of those things relate to synthetic suburethral slings.
I
Yes,
think that's quite an important point, because from the bowel point of view, the world is slightly different, and really mesh has been used in 3 indications broadly. So we've got urinary incontinence, as you say, with suburethral slings. We have vaginal support for vaginal prolapse, and the word prolapse is taken in under a guidance because it means different things depending on whether you're a urologist, a gynecologist, or a colorectal surgeon. Colorectal surgeons would call prolapse when the bowel comes out of the anus and hangs out of the anus, either transiently as a result of straining of defecation or permanently. And so in the bowel world, the 3rd indication for using mesh is for either obstructed emptying of the bowel, so someone has constipation, has to strain because of mobility in the bowel, causing it to infold and therefore block out the exit. And so the mesh is used to support it in place to enable a smooth passage of feces through the bowel during emptying. And the 2nd indication is for full thickness prolapse of the bowel out of the anus. Our data set is probably not as mature as the Urogynaecology and Urology data set. We do have the advantage of the largest systematic review of all of the evidence that we do have, which admittedly is from some randomized trials, but mainly large case series from around the world, predominantly Europe, because this is much more common in Europe than it is in the States and the northern continent. And we know that our complication rate related to mesh is in the region of 2%. Of those, probably 1%, so half of that 2% relates to mesh pain, mesh erosions and fistula formation, with the other half being detachment of the mesh leading to failure of the surgery but not debilitating morbid complications. Just to put things in, it's a much lower magnitude than one might see for the other indications.
So the failure of the surgery, is that about competence? Is that about training? Is that about education? Is that about skills? What is
inevitably, potentially it can involve all of those factors. The surgical community is very aware of training, competency, mentorship, learning curves. And so nowadays, I'm fairly confident in saying that surgeons are not embarking on procedures that they've not done before without seeking out training and the support and the mentorship. And a lot of what we've done is to provide a form of platform so that if you wish to start doing this, you can go through, you work out, most importantly, the indications and in whom to do it and when. But then we have animal models, we have cadaveric models, we have training schemes, and we're in the process of setting up mentorship so that your first few will be done with direct supervision of someone who's an accomplished, experienced surgeon.
Because prior to the pause, and we'll be going on to the pause in a minute, but prior to the pause, we heard the expression, they'll have a go. And that deeply worried us because we felt these were people who felt that they were competent to do it and they would have a go. And we weren't at all comforted by the fact that we didn't feel that the necessarily things that you've been talking about were actually in place.
Rest assured, I don't think any of us sat here are comfortable with those phrases either. And certainly from the Pelvic Floor Society, and I'm convinced that the Urogynaecology and Urology societies are exactly the same. And prior to the pause, we detected the public feeling and the sort of resolution that we see more and more problems, and so we could see the problem arising. And so actually prior to the pause, certainly the Pelvic Floor Society has preempted it by putting in place the bits to really sort of oversee professional conduct, both with training, with MDT working, with supervision, and starting the database and registries, which luckily we started about a year and a half, 2 years before the pause, and so hopefully we were hitting the ground running. But totally agree with you, and I don't think any of us would agree that have a go is appropriate. It's never been appropriate, but now
I would be appalled to hear that there was words coming out from any surgeon. As a professional society, we would find that completely unacceptable. We have developed a stronger or an updated emphasis to allow training to take place, which Swati's been leading on.
Yeah. So one of the things that we recognised when the pause came into place is how well equipped we were, or how poorly equipped we were, to deal with or offer a service to women with incontinence when the mesh was taken away as an option. And that made us stop, pause and think about how we were going to address that. And now there are two cohorts of people. They include the future NHS consultants, they include the doctors in training who will be the consultants of tomorrow, but then we had a huge cohort of consultants in practice who were either not trained at any point in their careers to perform the non-mesh continence procedures, or who had been trained but had just become de-skilled. And in response to the pause, what the BSUG have done in the past 6 months is set up a mentorship scheme for non-mesh continence procedures. We launched this in November, so within 6 months we've written the entire logbook. It goes hand in hand with supervised training, where a senior clinician provides proctorship to a junior consultant or a consultant wishing to either retrain or learn as a first, for the first time, one of these non-mesh continence procedures. But it also encompasses other aspects which go hand in hand with training, such as cadaver dissection, learning on models, because you can't just have a go on the patient. That isn't the way to learn any form of surgery. And what we have done through the mentorship scheme, we already have about 10 units registered, 10 consultants registered for this throughout the country. They identify consultants wishing to learn these non-mesh continence procedures. They identify a mentor. They then register with the BSUG. The BSUG then sends them a logbook, which then they then complete, and this logbook is then returned to BSUG, and then we issue a certificate to say they have had the appropriate training. This mentorship scheme has been approved by the RCOG, the Education Quality Assurance Committee of the RCOG, so we have the RCOG support and backing with this as well. But we see this as one of the positives that have come out from the pause, because it's made us stop, think, assess, and make things better.
How many are going to go through this?
So it's going to be very much at the discretion of the consultants, but we, as a consultant body, the one thing that we've all been hearing, and I'm sure I echo the views of all 3 pelvic floor societies, is that consultants will not just do a procedure. The days of see one, do one, see one, teach one, and yes, are gone. We are now in a situation where, until we've done several cases, multiple cases, until we're feeling totally confident that we can do it in isolation, we won't just go on and do them. So we've had expressions of interest from over 20, and you have to remember the email regarding this only went out under 2 weeks ago, and 20 people have already contacted us to be sent the details. It just shows the new wave within NHS consultants, and the recognition that if we're going to do a procedure, we need to be adequately trained, and we need to be able to demonstrate that we have had that training.
And what's your estimate of how many are needed to be trained?
That's a good question, and that comes back to what the caseload is going to be, and that's not I wouldn't want to pluck a figure out of a hat for that. I think that's work that we would have to do in collaboration with HES in terms of the total number of cases, because you have to remember this is very fluid. This is not a fixed number. So if we go back 5 years ago, virtually the only continence procedure being done was the mid-urethral tape. So you would need hundreds of clinicians to do that. If you look at the HES data from the same timings, the number of colpoid suspensions done in that same time was under 70. The number of autologous slings done was even less. But if we look at today, the number of colpoid suspensions being done is well into the hundreds and 200s, the number of autologous slings similarly. And so the number of clinicians required to carry out or offer a service will be very much dependent on the number of cases. So I don't think that we can answer that question in isolation. I think it has to be in collaboration with the commissioning bodies such as NHS England, which are working on just that. They are working on the caseload and then determining how many clinicians we need and how many units should then be offering those services based on that caseload. And that's fluid.
Can I say, I think that's encouraging, what you've been doing. But haven't you come to this rather late? Because what the women have been telling us is that they felt that they were guinea pigs in a sort of mesh trial, and that all this was happening, and there really wasn't the sort of, the things that you're promoting now, suggesting will happen. Don't we owe something to these women who feel they have been really, really badly treated, lives turned up to that, huge suffering, terrible impact on family and all the rest of it. And do you not think that they deserve an apology, and more than that, what can we do to help them now?
I think that's a slightly separate issue from your original question, which was looking at safety of alternative procedures. And again, we go back to the level 1 evidence we have, and probably the best out there was the Lancet publication from the Scottish group in 2017, which looked at adverse events after mesh surgery and non-mesh procedures for stress incontinence, and found that the mesh procedures were actually associated with a lower risk of immediate complications and a low risk of subsequent prolapse surgery, they had a similar rate of longer-term complications and a similar need for further incontinence surgery. So, you know, as surgeons, we're trained to look at the highest level of evidence that's there, and that's what we did. So I don't think women were guinea pigs in terms of primary mesh surgery. I think as surgeons, and certainly in my practice, I was looking at what's out there. I had Cochrane reviews, I had European Union reviews, I had RCTs, Lancet papers. That's a strong evidence base. And if you look at one of the statements in the Cochrane review, mesh surgery is one of the most highly researched surgical procedures there is. And we were relying on what was out there. I think what we're coming round to now is the realization is perhaps our outcomes weren't right, and definitely that our length of time we looked at these women wasn't right. Most studies closed at a year or 2 years. You know, what we need, according to the patient groups, are 5-year, 10-year data. So I think, yes, we do owe women an apology without a doubt, and I would give that unreservedly on behalf of BAUS. But I think you've got to put yourself in the position of the surgeon at the time who looked at the evidence available to him or her, and it's only more recently that it's come out that you know, these complications can firstly occur anything up to 10, 15 years after the primary surgery, and secondly, just how numerous they can be and how devastating.
But it's also about the type of complication, isn't it? So, I mean, you're right about duration and long-term complications, and we've certainly been told that by many women.
Yeah.
Some women experience immediate complications, some experience complications 10 years later, there are many in between. But it's also about the type of complication and whether the data that's existed up until now has adequately captured the real meaning of complication.
No, absolutely, I agree. That's why I said I don't think the outcomes in the original trials were correct. We didn't capture chronic pain, we didn't capture loss of mobility, we didn't ask about loss of sexual function. All of these things are massive you know, domains in the overall quality of life of an individual, but the trials looked at pad-free rates and, you know, overall patient outcomes where, you know, we could have done better, of course.
But if I can give you an partial answer to the question that you had, don't patients need an apology? Because I was involved with the NHS England and the Scottish Review. One of the things that actually came out of that, and I was chair of the Information and Consent, chair of that review, and one of the things that actually came out of that, of course, was are patients getting adequate informed consent? So you may have a trained surgeon who could do a TVT, TOT, or prolapse mesh repair, but were patients being offered all the alternatives and being informed properly? And it was quite evident at that time not all patients were. So one of the recommendations that came out of both the English and Scottish reviews is that every patient had the right to properly informed consent, that they had to have access to all the treatments. Now that doesn't mean that that individual surgeon has to be able to offer all the treatments, but the patient has to have access to it. That recommendation was put in by NHS England, and what is happening with both the British Association of Urological Surgeons and BSUG via the RCOG is ensuring that all patients have access to that. And one of the things that has happened as a result of the cancer drive towards multidisciplinary meetings, exactly the same thing is happening within urology and urogynaecology, such now that all patients, whether they're having primary or recurrent surgery, will go through an MDT, will have an outcome that shows them that these are the options they have, and then those options are taken to the patient for information and consent at that time. And if that surgeon cannot offer that procedure, then they should have access to all the others. But what we've got to ensure is that NHS England and the other devolved nations ensure that that is carried through to all patients.
I think that last point is crucial in that I was going to follow up on what Swati said, in that what has changed over the last certainly 5 years, and probably longer than that, is the fact that the MDT process has formed the cornerstone of delivery of care for any patient with pelvic floor pathology.
But it's not 100%, is it? And your own survey shows that it's not 100%. I think it was 85% of procedures went through an MDT, so we've got 15% that are not.
One of the difficulties that we have as the professional organisations is that we do everything we can to ensure that we recommend what should happen. We make it as user-friendly as possible. We give every resource to make it almost harder not to do it than to do it. But it still is down to the individual trust and the individual consultant, his or herself, as to how they conduct their practice. Without any other regulation, we have no authority over, we can only advise.
And therein lies the problem. We're advisors, not regulators.
Yeah, where we go.
And what came out of the review is every trust was written to, every medical director and every chief executive were informed of the recommendations to ensure the governance process came about. The one thing that we had done via Professor Keith Willett was also suggested that ideally there should be a key performance indicator. Now, if you have a key performance indicator for these outcomes, then the trust has to deliver on it. It's not an option. They have to deliver.
There has to be a mandate, though, doesn't there? I mean, so if you take the BAUS registry, for example, we have regularly captured between 70 and 75% of the stress incontinence procedures undertaken by urologists year on year, but that leaves 1 in 4 that we don't capture. So we've taken quite a lot of steps to try and ensure that that is increased, and one of the things we did as BAUS is we wrote to the medical directors of the trusts who we identified via HES data weren't putting their data in. We've got very little engagement, but that's because BAUS is toothless as a regulatory organisation. Therefore, we need a stronger mandate from somebody or an organisation perhaps like NHS England. And that's one of the things we're talking about at the moment, setting up the registry. So we've had engagement with NHS England and HQIP, and one of the things that we said at the very outset is this has to be mandatory. You know, and there's several other factors we've got to look at with regards to registries, but the key thing is that it has to be mandated. We have to get capture of all data for all stress incontinence surgeries, because we need to be able to say, well, if you choose procedure A, the likelihood of success is X, and the likelihood of complication is Y, and the same thing for all of the different formats. So that represents proper consent, and at the moment there are just so many blind spots in the evidence that we have to be able to do that. Although what BAUS did do is produce an options leaflet to try and encourage the sort of general discussion with the patient of all the options that are on the table. What I'm seeing at the moment is that, you know, women with stress incontinence actually don't want to come through for surgery, and you can see that in NHS digital figures, 48% decrease in stress incontinence surgery operations, and that's because we've lost their trust, and we need to regain that. And the only way of doing that is show a robust pathway from start to finish and beyond.
Well, thank you very much for saying that, because this is the other thing that's really struck us. We know that there are good surgeons in this country, highly respected, doing a very good job. But we've heard a lot from the women who've been harmed that they have really lost trust in surgeons. And there's, of course, the surgeons they've met. And we've heard a lot about denial. Surgeons who have actually denied that mesh is the problem, etc., instead of working with the women and other organisations. So you quite rightly said that you've got to ensure that you regain the trust you've lost. And you're thinking that you do that through data, through evidence, but I think it's more than that.
May I just pick up on the question you asked initially about did we not owe women an apology? And again, I think I speak on behalf of all of us when I say that some women have suffered devastating consequences from mesh, and that really isn't good enough. But I would like to assure the women who have had these problems that as organisations, as professional bodies, we have been trying for so many years. But again, it comes back to the fact that we cannot mandate anything. So in response to the fact that we had concerns about some clinicians possibly having a go, we set up the process of accreditation so that we could make sure that if a woman was asking for continence services in Aberdeenshire, it was exactly the same and standardised as it would be if she was having the same services in Plymouth. In response to the fact that meshes were resulting in complications, we set up a database. Again, we have encouraged and asked all members to database their cases, but again, it's not something that we can mandate. With regards to patient consent, even before the pause, and for over a year now, BSUG have been working in collaboration with RCOG, and we were due to publish our patient decision aids, which involves every procedure that is incorporated by the pause, so that women can make informed decisions. They can make decisions based on their values, because again, as surgeons, we know there is no surgery that is with no risks or complications. All of them have risks. And that is why it comes down to what is important to an individual patient. It is their right to choose, and we want to empower women, and by developing these decision aids, that is what we hope to achieve. Following on from the pause, we've now amalgamated the decision aids that we were working on with NICE, and these are now due to be published with the NICE guidelines in the first week of April. So this has again been a huge body of work that we have been working on in collaboration with other organisations, but it's all aimed at empowering women, giving them the choice, allowing them to make the decisions based on what's important to them and their values. So I do think we've tried our best.
Can I say, I have actually read all the stuff that you already put out for patients in terms of ensuring that they do have proper choices, they know what's involved and all the rest, and your consent form and everything. And I do think that's a huge step forward. So I look with great interest to what's coming out in April. So did
you mentioned accreditation, which is a big issue, and we are seeing presently urological surgeons and urological obstetricians and gynecologists later today, and that's one of the issues that we want to explore with them. Should there be a register of the accreditation for surgeons on particular procedures? This is not a new idea, I know, but what is your view of that? And would that be held by the specialist groups or by the Royal Colleges, and it has to then interact with the appraisal system and the revalidation with the General Medical Council? And I'd be interested in all your views about that, please.
Well, I think accreditation is part of the appraisal process. So within the appraisal process for a consultant, we have to demonstrate that if we are doing a procedure, we have been...
I'm thinking about, I'm interrupting, I'm sorry, is that this would then be publicly available, so that I as a patient could check a database that tells me that the surgeon who's operating on me is actually accredited to do that operation.
I think that would be a huge step in the right direction. I think we would all be very supportive of that.
I'd rather have your will, actually.
Right. One of my other hats is I'm chair of urological training within the UK, but across the board they're not too dissimilar. So a trainee, be they urologist or urogynaecologist or a pelvic floor surgeon, will go through a training program within their chosen specialist area. So from a urogynecological point of view, they will get to a point that they have to develop and deliver a certain level of competency. That will apply for the colorectal surgeons, and it will apply for the urological surgeons who've developed an interest in that area. If they are developing techniques beyond that area, then they go and get fellowships. And you will hear from Royal College of Surgeons and ONG later on. Some of those are accredited and some of them are not accredited. A group you may or not have heard from are the GMC at the moment, because the big move now is towards credentialing. So say for instance you have a consultant that comes out of urological or gynecological training now and has learned a technique, but like everything, we're consultants, a new technique comes around. What is likely to happen under the umbrella of the GMC is a credentialing in that procedure. That is something that we've been calling for.
And that would go on the register.
Sorry?
And that would be on a register.
That would be on a register. A credential will be on a register.
Which could be accessed by the public.
So you have the special interest training, you have fellowship training, and then you have credentialing, which will occur post.
Yes, because we go on learning all our careers.
As we go on learning through the careers.
So I lead probably the only Royal College accredited fellowship in female and functional urology in the UK. There are many other fellowships which are equally good, but the one in Newcastle is the only one that's badged by the Royal College of Surgeons, and we agree with the college prior to even being granted the fellowship, numbers of procedures and what we're doing. Obviously that's been a bit of a changeable feast lately with the mesh pause, but we do have that agreement in place, so anyone who's awarded the fellowship from my unit will have done a minimum number of procedures to a minimum level of competence. But I think what's probably coming with specialised commissioning is perhaps accreditation is not the right word, but designation and quality standards will be issued by NHS England, by which units will be commissioned, and that will come with complex incontinence, and it will also come...
Well, that is actually part of the pause, that the specialised unit should be established for mesh removal, and then they themselves would have to be accredited.
So I think that's, work that's well underway.
Yes,
Jonathan and I and others in the room have liaised very closely with NHS England to try and assign these quality standards, look at what's needed. And when we started out, we were thinking of very small numbers of mesh removal centres in the UK, but the demand is so high. You look at NHS digital data, and I think I worked out that the median number of mesh removal procedures of any kind was 60 per month from those figures. So 4 centres probably can't do this. We probably need double or even more with regards to that. And one thing we're working on with the specialised commissioning groups is to assign not just the competence of the surgeons, but the infrastructure in the units, because it's pathways that hold these patients up, as well as access to surgery, it's access to investigations, to scans, to urodynamics, to things like that. And I think we have to, any units that are going to tender for this, are going to have to demonstrate that they've got the infrastructure in place so that the pathways are streamlined as it can be.
So the service specification for specialist commissioning has been agreed and gone out for consultation and come back in, and it's due to go to the Women and Children's Health Board on the 28th of February for the specifications to be signed off. So there will then be specifications for the mesh removal centres and specialist centres. So when you talk about numbers, there'll be 40 to 50 specialist centres, and it's not then dependent on individuals, but those centres will have to provide a number of different surgeons who may concentrate on different operations. So there'll be the specialist centres providing all of the surgical procedures that patients may wish to choose from within the continence sphere of having their treatment if they failed conservative therapies. So that's all moving on very quickly, and also the mesh centres will be commissioned, whether we have 4 to 8, 10 to 12 or whatever. That will hopefully, so the process is in full force now and going through quite quickly to have those commissioned.
Can I just clarify, the 4 to 8 specialist centres that you've been talking about, that will be mesh complications, mesh removal?
Yeah, mesh salvage surgery. Yeah.
Mesh salvage surgery. 40 to 50 you're talking about would be the insertions.
Well, complex incontinence.
So they would offer they would be able to offer the breadth of continence surgery that a patient would be counselled from, and may choose any of the 4 current procedures that are recommended by NICE.
Can I just finish the credentialing question? Pelvic Floor Society?
Absolutely. We thought long and hard about this as well, as to whether to try to instigate a certificate of competency, for want of a better term, about any particular operation. Bearing in mind, none of that exists for any of the other operations that we've ever done, to my knowledge. We went further. If you look at where the problems occur with any particular individual, often they relate to the decision making, not necessarily the operation that's been performed, but the decision whether it's the most appropriate operation, and indeed is it indicated. A lot of it comes down to the consent and whether all of the other options and the potential complications were included. Without doubt, some of it will come down to technical competency of performing the operation itself, which goes back to how I answered your original question. But the majority, and I'd say 70%, were the former 2 points. All of those, the responsibility for patient protection and care, come under the umbrella of the multidisciplinary team service. So we would argue, and the way that we've gone about it in the Pelvic Floor Society, is to accredit units rather than individuals, which encompasses the whole process, the pathway. Into that, governance is written because it's not an individual. And many of the cases where problems have occurred, you may well have had an individual who clearly knows better than anyone else, who has dictated what the operation may or may not be, and therein lies the path of sorrow. If you have an NDT process, you will have rehearsed all of the other options. You will have ensured that non-surgical treatment options have been maximised to avoid surgery altogether. Within that is also, to be accredited, you have to demonstrate adequate review, entry of data into the database, audit of the outcome of the unit, and adequate training and mentorship of each individual within that unit. So I would suggest that we aim for unit accreditation, which can all be publicised. And we've set that up with the Pelvic Floor Society. There are now 2 units that are accredited in the country. I'm pleased to sit here and say that mine is one of them, but clearly if it wasn't, you'd have to ask why I'm sat here in the first place. But again, that is voluntary. There's nothing in it for anybody. There's no incentive other than pride of one's service. And maybe that needs to change, but for that to change, we can't do that. No, we need the weight of the NHS or the government to say...
We recognise this when we recommended the PAUS, and I guess that's also part of our responsibility to make recommendations, which is why we're all here today.
So I think it comes back to resource again. So as a professional organisation, BAUS would struggle to set up an accreditation process and roll it out, and it's amazing that BSUG have done that. But I think if you look at a logical comparator, which is the cancer MDT, in my hospital, the cancer MDT has an MDT coordinator, they have administrative support, they have radiology time, the consultant's time is job planned, and that doesn't occur for functional urological problems, and we have MDTs just the same as they do, and you almost need that driving force behind to make the trust say, well, right, this is a necessary component of a service delivery, and therefore will result.
That's a good point.
I think if
we look at the MBOCAP data for cancer for colorectal, and one of the prerequisites is, has the case been discussed in an MDT? What was the outcome? What is the management strategy? And you'd be the first against the wall if you said, I'm just doing the odd cancer here and there. I've done some that it's quite straightforward. I don't need to talk to anyone else. I mean, I'm being completely facetious because we're all laughing internally because it seems ludicrous. And yet we've got benign work where the stakes are so much higher because it's about quality of life. And as we've already heard, the complications, certainly from a colorectal point of view, is maybe 1 in 100 who has a major complication, but when it occurs, it is life-destroying, potentially, and we're fully aware of that. The difficulty comes is that the other 99 won't have had their lives destroyed, and at least 60 or 70 will have had their lives transformed for the better, so that they get on with their life as a result of the surgery. It's getting the protection and the balance right.
But a service that is a service for all means that even this 5, 3, 2, 1% for whom it goes wrong, the service has to be able to provide the right pathways. And what we hear from the women is that they do not know where to go. They are going round and round, they're chasing themselves because they aren't getting the help they need. So I hear what you're saying, but none of them can be left on a heap somewhere.
We totally agree with that, and none of us would disagree with that. And actually preempting this, we're already making moves, A, to get more clarity with who to go and where to go for help, number one. Number two, having more of a structured pathway so that we know what that help will look like in a structured way. And number 3, trying to avoid the situation in the first place by trying to get regulation or consistency in the process that's led them to have the operation in the first place.
It's taking a long time to get to this stage.
Can I
Because we're doing it with just because we feel it really needs to be done.
Yeah, the one thing I want to say is that we've lost 3 years. Because again, going back to the NHS England and Scottish reviews, two big things came out of that. Was that every patient had to go through the MDT process, but we needed the resources for it. Secondly, from a GP advice point of view, that all patients had to have access to GP advice. That wasn't resourced in Scotland. And thirdly, and more importantly, is the recommendations of the complex failures. At the time of 2016, when the MESH review came out, neither BAUS or Royal College of Surgeons are regulatory bodies. So we came up with self-regulation in terms of nominated MESH centres that we felt could offer the facilities. Not necessarily be able to treat everybody, but allow a patient into a pathway that then lent them on to treatment. So you had a port of entry, and that port of entry then allowed you to access amongst your colleagues, because some of these complications are very severe complications. You may not be able to deal with it, but your colleague may. And that colleague may be in a different institution.
I think that's a really important point. So one of the things we did to try and help the patients as a first port of call was point them in the direction of the BAUS website, where MESH advisory stroke removal centres were located. I think there were 20-something of them on the BAUS website, and not all of them were doing high volumes of mesh removal, and certainly perhaps only half of them were doing the complex removals, but it was a first port of call, because what we were hearing is patients were going to the GP with pelvic pain, say 8 years after a mesh. They were going for a hip x-ray or a back x-ray, and they're just, the pathway was so meandering that we thought, well, right, this is where, and it spanned the whole of England, Scotland and Wales, to give people a point to where to go first, not necessarily to see the surgeon who would end up ultimately treating you, but at least to get you on that path, to avoid this meandering before we actually get to, oh, well, it could be the mesh.
And we've had our first national meeting of mesh centres in December last year, where all the mesh centres came together to discuss how patients were imaged and treated, and to actually produce some guidelines about how patients should be treated and managed in future. So we have understood that problem, and within the context of a small charity, which is what we are, we've tried to address that informally or without any additional assistance from any wider bodies. So we've driven through patient care and safety. We've tried to, where we can, within the limitations of what we can do.
Can I just ask? Sorry, just a quick one. So all the things that you've been describing, the efforts you're making to address the problems that you, I think, all recognise exist, have they not all come about because of the efforts of patients organising themselves into groups?
I would say we started way before then. The accreditation of units that was set up by BSUG is now 6 years old, and it goes back to what Sir Shantler was asking about credentialing of clinicians. The whole aim of the BSUG accreditation process was to make sure that the people performing the continence and prolapse procedures had the certificate, had the knowledge, had the skills to do so, and that's what the accreditation system did. It made sure that certain standards were being met, and though we were accrediting units, it was the clinicians within those units that had to demonstrate that they met all the criteria, which is a form of credentialing. And this is now, we've had several units now re-accredit because they have to be re-accredited after 5 years. So this is going back a fair few years.
Until the pause came into effect, women were at the hands of have-a-go surgeons. Right up until that point, they were lacking the ability to give informed consent. When complications did arise, there was and still is no clear pathway for them to go to. And the pressure that you're responding to, it seems to me, is largely from those patients and the politicians who've taken an interest in their cause and it wouldn't be happening if
I think that's fair. I think that's fair. I think that's a fair point. I think that they've raised awareness and they should be congratulated for that. Certainly the patients getting themselves together in groups. You know, you've got, like, I take you back to what I said at the start. You know, we believed what we saw in the level 1 evidence we read, you know, which was these procedures were quick, straightforward, largely successful and free of significant complication. And of course only the patients alerted us to the fact that they were getting it, but we were all sort of starting to see more and more come through in our practice.
I think both are true. Clearly,
Yes.
movement was made prior to the massive public interest, and we knew that there were certain problems. Certainly from a BAUS point of view, okay, our incidence is far lower, but it's not zero, and when it happens it can be catastrophic, and so we take that very seriously. There's no doubt that the public concern, the pause, has driven this at a pace, which actually, personally speaking from the Pelvic Floor Society, we welcome, because it's given us a platform and it's given us some momentum to actually make some change and make some difference. Because otherwise, as we said, we can advise and we can suggest and we can say, well, we would do this. But the root of the problem, and this has come up time and time again, but none of us have said it, is that the surgeons for whom you're not worried about are the ones who are engaged, they're interested in communication, consent, they're members of our societies and active members, and they are proactive. That's great. You don't have to convince them about MDT working and everything else. The difficulty comes is, as you say, up until the pause, you'll have people who say, well, that doesn't seem too hard, I'll have a go at that. And clearly I'm being, blasé about it, and it's never quite, hopefully, that blasé. But those are the surgeons that we need to be watching and we need to bring into the fold to work as part of a team. We have no power of doing that.
But I think there's been a fall off.
Can I just say, I mean, I was really interested, Mr. Morley, what you were saying, that we'd lost 3 years. In those 3 years, a lot of operations have taken place. I am sure some are successful, some I'm sure have caused terrible complications and difficulties. So I absolutely sense your frustration, because you are not executive, you are a membership organisations and all the rest of it. But what I just want to pick up is that you're saying you want things mandated. What does that mean? Who does the mandating? How do you ensure it holds? Where are other examples? Could you just tell me a bit more about mandating?
But can I answer that? That's always been the difficult problem, and that's been the problem right from the start, and it's the main problem today. If we came away from this meeting and you could mandate compulsory use of the registry and a variety of other things,
we can't do anything.
I know.
We can only recommend. And actually that's why we had to work very hard to get the pause to happen. Because we couldn't do it, we had to work with NHS England and the Department of Health.
I would be the happiest man, and probably with the whole group here, if we could mandate the things that we've been trying to achieve as societies for many years, and mandating registry would be the way forward. The problem comes when we've had these discussions with NHS England, is they say they can't mandate care because they buy or purchase
they're commissioners.
services. They're commissioners. So we fall within this area where there is no one to mandate the care. We try it through the governance system and the appraisal system, but actually this is the crux of the problem. We can't mandate these things, and we would love them.
But why cannot?
Sorry. Who can?
Yeah.
Who can
Few
mandate?
commissioners can, because if you say that the commissioners will only pay for a procedure, if you can fill in the, or I'd hate to say fill in the form, but you can prove that they've gone through an MDT process, you can prove that they come from a pelvic floor unit, you could add into that initially a sequin benefit for a accredited unit. I think if you make it only accredited units that are able to be commissioned, you would stall the whole of pelvic floor services nationally, because there won't be enough units that can do anything. But you could start by saying, right, we recommend a sequin target for accredited units, and if you are going to be paid, because it all comes down to money, whether we like it or not, You only get paid for a procedure if you can prove that it's gone through an MDT and you have the correct governance.
So the classical example of that, where it works well, where there has been a sequin and key performance indicator, is cancer.
Yeah.
And if you used the cancer pathway model for this, you would get those outcomes. Because the people that are not trained basically give up and are not accredited, so they fall by the wayside. You only get those people that are doing them properly, in high volume, going through the whole MDT process, that do the surgery.
Right. Thank you. Right. I think a lot of people wanted to come in and
I'd like to just deal with consent. One of the recurring themes as we've gone around the country, and we've met hundreds of people now, personally met them within the team, as well as met them on the line and in correspondence, and we've observed people who have terrible suffering. And one of the complaints has been, I never was told what was going to happen. Now, I accept the point, you can't know what you don't know. I mean, and it's the unknown. And we didn't have the outcome measures to do that. But the process sometimes seems to have been quite extraordinarily trivial and unprofessional, if explained if it actually happened as it's been explained to us. So the question is, how can we actually improve that? In my practice, I would always sort of try and write a letter after we've done that and send a copy to the patient as well as so forth. But maybe in this day and age, and particularly with Montgomery and the things that go with that, we should have a more formal consent process, because it's a process and not an event. Can you think of any ways that could be improved? Do you think people should keep an audio record of it on both sides, or can you think of anything that we can do? Because we get back to this issue of trust at this point.
The patient
let me finish, which is an important part to me of being a doctor. You've got to be trusted for medicine to work. So what do we need as a profession to do to improve that? Jonathan, I interrupted you.
Sorry. The patient decision aid is one of the cornerstones of making sure that patients have full choice and informed consent. And yes, I think the consent in the past was not as good as it could be, and I think we've learned from that within this process. So within the new patient decision aid, they will have all the risks and complications that we are aware of at this moment explained to the patient. Then it's the patient's choice to decide which operation they would want surgically. So I think that's a great step forward, and I think it does cover Montgomery, and it within as good as we can allows the patient to be fully informed. We've done some work with some qualitative work looking at consent, in fact, and with the London School of Tropical Medicine and Hygiene with an NIHR grant, and it involved interviewing patients before they'd had surgery, so they were naive to the treatment options, and it is very interesting to determine what makes patients choose surgery and which operation they actually want. And there were many other things which, other than the surgical success and the complications, the drivers are actually for patients choosing surgery are where they are in their life, and they take advice from the woman down the road who's had an operation. And so there were many different drivers that we're starting to understand about the consent process. But it's not what we're doing at the moment is we will hopefully give them the risks and complications and allow them to choose. But that isn't what makes them make their decisions. It's other life factors that are really important to them.
But can I just say, I have already paid a tribute to your decision aids. That is a presumption that people can read, that they'll take it home and all the rest of it.
Yeah.
What patients really want is the quality of the consultation that they have with the surgeon or whoever is going to be advising them, and the operation involved and so on. Now, when I chaired a trust, at that time, the surgeons then, because it was old world, used tape recorders. They put it on and they recorded everything that was said in that consultation. The patient then took that home with them. They discussed it with their family, and really it brought out all sorts of other issues because their family were just as concerned. And then they went back to the surgeon and said, look, these are the questions that now we want to ask you. The decision aids are telling people, no, we are saying that actually it is the patient's choice. It is up to the patient that has to be well informed, and that takes place apart from anything else, of the quality of the consultation that's taking place. Now, Sir Cyril has said that with the modern world, of course we've got iPhones, we can record stuff. Now, don't you think it would be a good idea if we moved forward and in this case then actually ensured that the patient had a record of the consultation that took place, discuss it with their family and others, and then come back with their questions?
We've got the options leaflet from BAUS, and it's designed to be filled in the consultation, and actually I write down where it says, you know, I would want this option because, or I would not. I fill it in with the patient, and that's, you know, to me a proper consultation with fully informed consent, because we take every option, I give them the facts, talk about whether or not it would be for them, and write down what they've said to me about why they perhaps would or wouldn't choose.
Do you give them a copy of the
form?
form?
They get it. No, they get it, and they bring it back, and then it goes in the medical notes when they have their surgery. So they get that, and that's why I think the options leaflet for BAUS is a very good idea, because it's no good as a leaflet you give to a patient to take away. It's about a recording of the conversation.
Yes, but what you're telling them is often not what they're hearing. And so we've actually been given, in some of our sessions we've had, patients coming with their patient notes, and they're very full. And the area where they had mesh inserted has been snow-pegged out. So that has gone from the record. Now, I'm not suggesting any of you do anything like that at all, but I'm just saying that I think that what you fill in, it's your view, and I'm sure it's full of integrity and professional and everything else, but the patient may not be hearing that.
No, but it's not my view. I write down what the patient tells me as their opinion on when they're first given the information about, because it says, I would like this operation because, and that I refers to the patient, not me. I can do all of them, but I record what the patient says, or perhaps I wouldn't want injectables because it really only works 50 to 60% of the time, or I wouldn't want an autologous sling because it needs 2 incisions. And you know, I write those things down, and then I say go away and have a think about that, and that's why the decision aid, the options leaflet from BAUS is such a good tool, because actually all you're recording is not necessarily what you're telling the patient, because that information is printed. It's what they then tell you about their initial thoughts, and it gives you a sort of window into the thought processes of them. And it's, as Jonathan says, it's so variable. I've got patients in Newcastle who are waiting for a mesh pouch to be lifted so they can have a tape. And they, you know, these are people who've weighed up all of the evidence. But you know, individuals will vary, and then I've got other patients who say, I'm never having any of that mesh, I've seen it on Victoria Derbyshire. You know, it's so different across the board, and that's why you need all the options to be outlined, and you need some record of the conversation that you've had and what the patient said to you.
So if I can make a comment about record, and you're opening up a whole big can of worms in terms of informed consent, because it's not peculiar just to matches.
That's why we're doing this review.
Across the whole of service.
This is modern medicine.
Yeah. But if you actually just go to the GMC website and good medical practice, there is a whole ream there sitting there on informed consent. And in any consultation, you need to discuss the procedures, the alternatives to the procedure you're recommending, what the risks of that are, and what questions the patients have got for you, and that should all be recorded. And certainly when I do my letter that goes out to the patient, that whole letter with all that discussion goes in the letter. Now that doesn't happen with everybody, but it happens with good practitioners. They will do all that. But you're talking about changing the face of what we're recording. Going back to recording now, with the latest changes in GDPR, you actually can't do that. They actually can't record, go back, come back with it, because that may have gone viral on the internet, tweet, or whatever. So we've got big problems with data protection.
I do know a bit about that, and I'm not sure you're right, but it's not the subject.
But yes, but I mean, we are opening up a whole realm of discussion.
As somebody who did once chair the the Committee on the Summary Care Record.
Right.
If you get permission from the patients, then you can do pretty well everything in that way, but you have an absolute requirement, unless it's a legal opt-out from GDPR, to restrict the information to the medical team and not beyond it. But patients, thankfully, can still do what they want to do, but you can't do what, or you wouldn't do, but people can't do what they might want to do with patient data without asking them. So, but I don't think that's the defence, but there are other issues here.
I think the BAUS decision aids include recognition of unknown territory, as it were. So what happens if a woman falls pregnant after the insertion of mesh and how that reacts and so on. How often do you get women saying to you, any of you, in the case of SUI or prolapse as was, what can you tell me about the risks of having polypropylene in my body for the rest of my life?
It's not common.
No.
It's not common.
Do you think it's a good question?
Yeah, it's definitely a good question. But
and what is the answer?
I don't know what the answer is. I was just about to say I don't know what the answer is in terms of long-term effects. I mean, my engagement with the patient groups has shown me that there's quite a lot of patients coming forward with autoimmune disorders that they relate to mesh, and there is some moderately supported evidence with regards to that. So, I don't know what the answer is, I have to say, but
there's an MHRA position statement on polypropylene mesh that was published in the International Urogynaecology Journal a couple of years ago. But yeah, I think, as Chris says, we're not 100% certain what the long-term risks and complications are, and hence why we do need to study these procedures longer term. I've just written a paper for another paper for the International Urological Journal, looking at the reaction in the body to mesh and things, and we, understand there may be inflammatory markers which are elicited or caused to develop by mesh in some patients. But our understanding of the science behind that and how it relates to systemic disease is quite rudimentary at the moment.
So when women tell us, as they have done on many, many occasions, that they feel like guinea pigs, you still think they're wrong, I think.
I think history will give us the answer to that. If in 100 years' time there's a clear development pathway between having polypropylene mesh and developing a condition, then clearly we've been ill-advised. The trouble is we're only seeing one side of the argument, in that supposing your risk of an autoimmune mesh-related complication is 0.1%, do you then leave the other percentage wet, prolapsing, incontinent? And it's a balanced argument. Nobody in this room will underestimate how devastating a bad mesh complication can be. We all are in agreement with that. We're all advocating a responsible, structured, MDT, robust process to counsel, consult, consent, and deliver surgery in the safest way possible. Follow patients up for as long as we think is necessary, and we don't know how long that is. But equally, to say yes, it could cause an autoimmune, therefore we will ban all mesh. Mesh will be used in hernia repairs, it's used all over the body, and if we stop using mesh, you will put surgery back by about 50 years. You'll be back to a 20% recurrence rate, 30% for a simple groin hernia, whereas at the moment it's less than 1%, probably 0.1%. And so we have to put everything into perspective, which is why I say we can't answer that question. And this is what I tell women and men when they say, I'm not having that mesh put in my body. I said, well, totally respect that. This is what else I can offer. These are the pros and cons of that. This is the evidence as far as we know it at the moment. Clearly things can change. You tell me what you would like. Absolutely. And it comes down to the Montgomery clause, where the checklist, and Shabab will tell us that we've produced a similar checklist for consent, mainly as an aide-memoire and a discussion point, because it is no longer adequate for me to say the chance of mesh erosion is 1% in this big systematic review, your chance of pain is 0.5% in this review, your chance of this, because we will say these are the published literature, but I will then say I have done 120 of these operations and I have had 2 mesh erosions. One was treated very simply, the other one it destroyed that woman's life. She then had to have this section of bowel out, she had this operation, and I spell it out. Because if you say to a woman, if she may have a total understanding, you say mesh erosion, she knows what that means. But I say, do you understand what that means? And I said, well, yeah. And I said, it means you could be passing feces and gas through your vagina without your control, such that you become burnt, excoriated and ulcerated around the vagina. You live in daily pain, which cannot be controlled, and even if we take the mesh out, it will still be in agony and it may be incurable. And so spelling it out in those words is now what the majority of the responsible consultants, and I think we're all nodding, will say.
But then you have the other variable, which is the variable patient views. I have, as I said before, women who are waiting to have suburethral tapes because they've looked at the literature and decided that actually the odds are in their favour. You know, the likelihood is they would get a good response, which is complication-free. You know, the HES data tells us 94% of patients don't have a readmission or a reoperation, and similar from Jonathan's group's work. Whereas those patients, they don't want the alternative because they know about the complications from colpo suspension or Tolga slings, which are significant. Whereas on the other hand, I have people who won't want mesh at all, who won't entertain the thought of it, but it's about empowering patient choice. That they've got to make the decision. I can't make it for them. But the worst question I dread is, what would you do if it was your wife? Well, they don't want that, you know. They need to make the decisions of what's important to them by weighing up the facts, because there is no operation that is complication-free. At the meeting in Sheffield, we had the chair of the British Pain Society standing up and telling us that up to 10% of patients after any major abdominal surgery got chronic pain. So, you know, there's nothing we do that is risk-free, not a thing.
But on the issue of consent, I think we would all agree that we haven't done justice previously. We haven't done as well as we should have done, and the consent process did fall below a reasonable standard. And I think Montgomery changed that. Montgomery made us aware that we needed to talk about all the options, and that's one of the things that the patient decision aids are very much designed to address. So the patients have to write down why they're choosing something. They have to write down what's important to them. So it may be that the fact, you know, as Chris was alluding to, it may be that the fact that they don't want to mesh is the single most important factor, in which case a mesh procedure is just not an option. But it may be that actually what is most important to them is a very short hospital stay, in which case it might be that in that patient the midurethral sling is the most appropriate procedure, but that's for them to decide, not for us. The other component we've incorporated into the decision aids is actually a page for the MDT to write, so that it demonstrates that not only has a patient made a decision, but that has then subsequently been discussed within an MDT context to, in some ways, confirm that that decision is appropriate. Because, for example, a patient with a BMI of 45 may decide that they want a laparoscopic colpo suspension, but they would be hard-pressed to find a surgeon who would be willing to do that. So it comes back to the appropriateness of the patient for a particular procedure. But the first thing that we have to bear in mind is their choice and their decision before we can then percolate that through to the MDT.
Well, thank you. We're absolutely one with you on that. Thank you very much.
Just put a
I'm
quick
going to have to draw
reality
this.
check.
I'm sorry. I'm going to have to draw this to a close because we've got other meetings, I'm afraid, this afternoon, and I'm trying to keep to time, and we have overrun already. But can I thank you so much for coming? I'm really, really grateful, and it's been a very, very interesting and informed discussion as far as I'm concerned. So thank you all very much.
Thank you very much.
Thank you.
Thank you.